get this going here. Okay, great. So I'm going to go through all this real quick. We're a P&A organization. What we do is protection and advocacy for persons with disabilities. Every state is mandated to have such an organization. They can take a variety of forms. We set ours up as a nonprofit legal corporation or law firm, okay? And we do have some of my VR people here today, and they're in the audience. You probably already introduced yourselves. But so what we do is we're all around the nation. We're part of a bigger network called the National Disability Rights Network. And as I stated, every state has one such protection and advocacy agency. So we are funded by state grants. That stands for Texas Access to Justice Foundation. But primarily, the bulk of our funding is federal grants. And one of them is CAP. So, which is what we do is our VR grant. We also have another one, Karen Pabs, where we assist persons with disabilities to like ticket to work kind of thing, where they can maintain their benefits and go back to work. So we help persons with disabilities understand and exercise their rights under the law, ensuring their full and equal participation in society. And that's our mission. We advocate for, protect, and advance the legal, human, and services rights of persons with disabilities. And we do that by providing direct legal assistance. By that I mean there's other folks that do indirect legal assistance, and I'll give you the name of one of them before we leave because I think it could be a good resource for you. But by direct, that means we actually take your case. We don't refer you to people. We don't, well, sometimes we do if we can't take it. But we take your case. We may take it to court. One of the things, for instance, my team is doing, we filed class action lawsuits. We filed all kinds of lawsuits. So we'll actually do that. But we try to also, particularly with our CAP team, resolve things, because that's our rule, at the lowest level. So I don't want you to come out with this impression that you call us because you want to sue somebody, or the folks who think they may get sued, that we're the guys that sue you every 5 minutes. In fact, for my VR state people, we never sue you. So I don't think we're allowed, right? Oh, we did one time. Okay, before I got here. Okay. I'm not going to sue you because I don't do VR. Okay. So I'm a good guy. All right. So we advocate for laws and public policies that protect and advance the rights of people with disabilities. And we inform people with disabilities and family members about their rights. We make referrals sometimes to programs and services. And why do we do it? Because disability is a natural part of the human experience. If you are lucky enough and you live long enough, there's no way you're not going to have a disability. Disability is diverse, okay? It's not just someone in a wheelchair, okay? It takes all kinds of forms. Some disabilities a lot of them you can't even see. And in some cases, those are the clients that have the most problems dealing with this, I'm gonna just call it the system, because folks just don't think they have a disability. So it does not diminish the right to live independently or to exert control and choice of your life. That's one of our big things, is that persons with disabilities always have the right to make their own decisions, and that right isn't taken away. And one of those decisions, why I'm here today, is we have a lot of our clients who want to work. And there's a lot of folks who just, for paternal reasons, think, no, you can't work. You shouldn't work. You're going to hurt yourself. You're going to hurt me because you're going to get, I used to do workers' comp. You're going to get hurt on the job. You're going to sue me. There's a million reasons, right? That's why there's a whole title of the Americans with Disabilities Act devoted to employment discrimination. It's called Title I. And there's a whole act for that. And that's the only area of law that gets its own act, is employment discrimination under the ADA. People with disabilities are at a greater risk for abuse, neglect, exploitation, and violation of legal and human rights. So our job is to try to be the watchdog, and when we can, intervene or intercede and try to help persons with disabilities. So again, how do we do it? We secure human, legal, and service rights through the judicial system. I already talked about that. We do a lot of administrative work. So one of the things we do is Medicaid appeals. If that's something, if somebody's here and you're having an issue, somebody is trying to get through a Medicaid benefit, and I'm going to talk a lot about that, and it's denied. We are one of the few organizations that handle that. Reason why I say we're one of the few is because there's no money in it. And I'll talk more about Medicaid and why there's no money in it, but let me say this about my profession, lawyers, because I'm going to pick on everybody today, so let me start with us. We don't normally get involved if there's no money. That might be a news flash for you. Us and doctors, rim shot. They have a better press agent, though. Establish and expand rights and services through advocacy efforts, inform policymakers, governmental officials, and the public of rights of people with disabilities. We do not lobby. We're not allowed by a grant. And we make referrals again to relevant programs and services, divided into a variety of teams. That first team, they won the award for the snazziest acronym. HEAT stands for Housing, Employment, Accessibility, and Transportation. I always wonder how long it took them to come up with that, HEAT. For the worst name, URCL, Institutional Rights and Civil Liberties, they put no time into coming up with that. Education, they do special education. PABS, I think you got your name because that was just the name. I don't think you had any input on that one. Not very snazzy. HAVA, that's a pretty good one. Help America Vote Act and foster care. And we are, of course, because I'm here, the Community Integration and Healthcare team. We're just wanted to put us up in lights in front of everybody. That's why we're bold and big there, right? No, we're our own act. We have a PAIR Act. There's a PAMI Act. PAIR is general disability. There's PAMI, which is protection advocacy for mental illness. And then, it was rehab. Then I want to say it was rehab. Then some of our acts that funded us. And I'm not sure if the ADA was around the same time. I'd have to go look at the history. DD was first, right? Yeah, but DD wasn't before rehab act. It was? That's my historian, so she would know. I did see that video. Okay, so, and so I didn't realize that we were before the 504, the PADD. I did not know that. That's interesting. Okay. Well, you can ask her. She knows. Yeah. Nah, it doesn't make me look bad. She answers questions for me all the time. I always say my team makes me look good. I don't know. So I just make speeches. So so what kind of disabilities do we deal? We deal with everything, but this is just a list of them, not exclusive. Developmental disabilities, physical disabilities, mental illness, emotional impairments, learning, traumatic brain injuries. I know you guys deal a lot with that one. Intellectual disabilities, sensory disabilities such as blindness or deafness, autism, adult onset and chronic health conditions, so I'm talking about maybe geriatrics in nursing facilities. It could be diabetes. It could be. We refer cases to Adult Protective Services, and we will double check their work, if that makes sense. Okay. Yeah. So we call it secondary investigations. All right. So disability by the numbers, because the thing you want right now at this time of day is statistics. All right. About 56.7 million people, or 19% of population, had a disability in 2010. That's the latest census information I can get on this. According to a broad definition of disability, with more than half of them reporting the disability was severe, and this is according to the U.S. Census Bureau. 41% of those aged 21 to 64 with any disability were employed, compared with 79% of those with no disability. So you can see that disparity, and that's an interesting thing. What does disability mean, right? If you talk to the Social Security Administration, it means you can't work. Right? Right. Or at some point they shut you down, that's what I like to say. But that means basically you can't do any gainful employment for 1 year, to be disabled. But that's not what we think of as disability. Okay. The ADA, the 504 Act, as you mentioned, it's a broader definition of what disability is. It could even be that you're regarded as having a disability. You don't necessarily have one, okay? Because it's not disabling you, but you have some health condition, and people are treating you like it's disabling you. That happens a lot with mental health. Someone has something that's under control. You could have someone with, I don't know, some kind of other health condition, and they don't want to deal with you, and they treat you, they regard you as having a disability, but you're really not being disabled. You can do work, you can do things. So, and now you see a lot of that. That would have been a good segue when I talk about health insurance. There's a lot of that in the health insurance, the mindset of what you're going to cost me, okay? So, let's see, 41% of those with age 21 to 64 with any disability were employed, again, compared to 79% of those with no disability. Along with the lower likelihood of having a job came the higher likelihood of experiencing persistent poverty, that is continuous poverty over a 24-month or 2-year period. Mm-hmm. Mm-hmm. Right. Are you talking about the two? This is from the U.S. Census Bureau. Okay. Mm-hmm. Well, yeah, I think I think I see where you're going. I can tell you this, that as Pig as attorney, I'm just presenting these numbers, but I can tell you we have experts. We call it the battle of experts, and one person comes up and they say something, and we bring an expert and we question the methodology and all of this, and we go round and round, and then the judge decides which one is right, which is funny because the judge probably knows the least about it of anybody. So, so yeah, I'm not, as far as the methodology, I can't vouch for it. Yeah, I was just using but I hear your point that, yeah. No, it's okay. No, it's fine. It's fine. And it's probably going to apply to the next slide too. So my answer will continue the same. Okay. Among people 15 to 64 with severe disabilities, 10.8% experienced persistent poverty. The same was true for 4.9% of those with a non-severe disability and 3.8% of those with no disability. And again, this is Census Bureau numbers. People in the oldest age group, 80 and older, were about 8 times more likely to have a disability as those in the youngest group, which is younger than 15, is how they broke them up. 71% compared with 8%. The probability of having a severe disability is 1 in 20 for those 15 to 24, while it is 1 in 4 for those 65 to 69. And what you do bring a valid point. This is based on a survey, whether it's scientific or not. You know, but these were the numbers I could find. Adults aged 21 to 64 with disabilities had a median monthly earnings of $1,900, basically $1,961 compared to $2,724 for those with no disability. Now the next statistic is from the World Health Organization. So this is more than America. People with disabilities report seeking more health care than people without disabilities and have greater unmet needs. For example, a recent survey of people with serious mental disorders showed that 35 and 50% of people in developed countries and between 76 to 85% in developing countries received no treatment in the year prior to the study. And again, I said earlier, disability is extremely diverse. While some health conditions associated with disability result in poor health and extensive health care, some don't. But it can still be considered disability. Per the Center for Disease Control, CDC, studies have shown that individuals with disabilities are more likely than people without disabilities to report poor overall health, less access to adequate health care, and increased smoking, which I didn't know that, and physical inactivity. Well, I could understand the last one. So healthcare in the United States, this breaks up into basically, and it's more than this, but I want to talk to you guys about the system and navigating it and how it works. And think of this in terms of the barriers. And the way I always tell folks, when you're trying to understand healthcare, it's the way it's set up in the U.S., and this is not an endorsement or an indictment. Okay, let me be clear on that. It is what it is, and I deal with it the way it is. I don't know how it is, it is. The way I always explain to folks, particularly when they join my team or I'm trying to teach somebody, is you think of it like money. Because at the end of the day, that's cold, that's crass, that's insensitive, there's a lot of things, and you're right. But that's how it works. Who's going to pay for it? Okay? First one, private insurance. Second, Affordable Care Act, which is a kind of a hybrid of private insurance and Medicaid. A little dash of Medicare, but not really. It affected Medicare, but not really. And then last is Medicare. So private insurance, that's what I'm assuming most persons in this room have. It's insurance that covers the whole or part of the risk of a person. And when we say risk, again, think of it like money. How much is it going to cost to take care of this? A whole or part of the risk incurring medical expenses, spreading the risk over a large number of persons. To understand how insurance works, the idea is that you put people in a pool and you share risk. Risk being costs, right? Healthy folks will offset not healthy folks. That's the idea. The bigger the pool, the bigger a sample of types of health conditions you get, the more the risk is spread out. Theory being that it keeps cost at a certain equilibrium, right? Group. This is what most people have. This is what you get through your job, right? And when you're in a health policy purchased by an employer and it's offered to eligible employees of the company and to be eligible, and sometimes the dependents and other persons in their family. As of 2016, the majority of non-elderly Americans, 56%, have group health insurance coverage through their employer or the employer or family member. And this is like, most cases, the best thing. Well, depends on the policy. A lot of times this is pretty good, but I've seen some policies that are pretty bad, okay? But then there's individual health insurance. Not a lot of this going around. This is someone just buying insurance. This has become a sort of a hybrid now too, but I'm going to talk about the Affordable Care Act because now you have a lot of exchanges where you're kind of going into a group, kind of a quasi group, but it's not as clean as when you're in the employment group. So I can tell you this. Here's an interesting thing. Depending on the size of where you work. Now, a lot of y'all may work for the state, but if you're working for some small place and you're in a group, it really gets interesting because somebody can have cancer and make all the rates double for everybody else. That's depending on how big your group is. The bigger the group, the better chance you got because the costs get spread out, right? But if you're like a small group, 50 people, cancer is $1 million, $2 million. Minimum. Unless it's just some like melanoma skin and they cut it off, but some real aggressive stuff, it's $1 million. So another thing I do for my agency is I help negotiate the rates and pick the health insurance. So I get to see a lot of this. I also used to sell health insurance in another lifetime. So I had a license to do that. So I've seen all sides of health insurance. So the Affordable Care Act, also referred to as Obamacare, was lauded as putting in place strong consumer protections, providing new coverage options, and giving the consumer the tools they need to make informed choices about their health. Criticisms, socialist, that means, again, they're spreading the wealth idea. Too expensive, massive expansion of government denies basic freedoms. And the idea that they're talking about there is that somebody could theoretically decide that they don't want to be in the system because they're relatively healthy. Maybe they just don't believe in health insurance, so they don't buy anything. And then the way the law was originally set up with the mandate, they get dragged into it because now they have to pay something, either get insurance or pay, and now they feel like they're being imposed upon and dragged because now their money is going in to cover someone. Let's say they don't get sick that year. Their money is going in to cover someone who did not get sick. However, the flip side of that, okay, is that the proponents of it say, yeah, but that person goes to the county hospital, or they get if I'm in Harris County, a Harris County, they call it gold card. It's also called hospital district cards, and then we all pay for it. Because we would like to think in a civilized country, no matter what, we're not going to let you die in the street, okay? Or they can wind up in a nursing home, and then that's like $500-600 a day. So here you go again, right? So it was upheld. You know, everybody heard about the big case. It was a big challenge. Justice Roberts, I think, made the tie-breaking vote. Justice, I can't think of his name. He dissented. It's escaping me right now. But it was upheld in National Federation of Independent Business versus Sebelius, and that was the Secretary of Health and Hospitals at the time. But when it was upheld, it was a caveat: states could opt out. If you live in Texas, you're living in a state that opted out. Okay. Well, they opted out of the Medicaid expansion. I'll talk about that later. That's a little different. They could opt out of that part. The individual mandate just got repealed. Does everybody know that? Okay, a lot of people don't realize that the law that says you have to, because that was a tax law. And the reason it got upheld in court was they said that it was just basically the way they did it, it was set up, and it gets too complicated. They said it was basically the Congress's exercising their power to tax. But they said that the mandate, the expansion went too far because that was an imposition on states. That was different. But the mandate, because it was a tax law, when they just did the new tax reform, they took that out. So you're not required to be in it. And I haven't really examined that yet, but I know you're not required to be in it if you're in a state that opted out. I'm not sure if you're in a state that stayed in, do you still have to have health insurance? I'm still researching that. It's still confusing, and they haven't really put it all together yet. So highlights: it ended lifetime limits on coverage, lifetime limits on most benefits are banned for all new health insurance plans. Did y'all know they used to have that? I don't know if people knew that. Like, you could have health, before this, you could have health insurance, and let's say I said you had that cancer and it kept coming back, they could just cut you off. People didn't know that. Like, they think, oh, they're just going to keep paying. Nope. You keep paying your premium, they'll cut you off. You hit the limit. Well, they got rid of that, thank goodness. And this stuff is pretty popular. I don't think most people argue about any of this stuff. Keeps young adults covered. You got your kids in college. You want to keep them on until 26. Before that, they got kicked off, I think at 21 or something. It ends lifetime. I said the lifetime limits. That's actually a typo. I didn't mean to have that in there twice. Sorry. Ends arbitrary withdrawals of insurance coverage. What that meant was, like, you made a mistake. You filled out something wrong. You sent it to the wrong address. And, guess what? You get diagnosed with something and they kick you off. Like, no, that's an honest mistake. You can stay on now, okay? I was not saying they won't fight you about it, but at least you got an argument now. It reviews premium increases. Insurance companies must now justify unreasonable rate hikes. Before this thing went in, I don't know if you guys knew this, the insurance rates went up, like, dramatically And there's a lot of theories as to why, but they at some point they were told to stop doing it. Some people thought it was them just trying to get their last big hit. Depends on what you think, but they got told they can't do that anymore. It just went up, it wasn't based on experience rates. You guys know about experience rates? Experience rates meaning like your experience, like how sick you get, how much it costs to gain money, how much it costs. It just went up. Like you could have had nothing and your insurance went up. Okay? Your whole group I'm talking about could have had nothing wrong with you and your insurance went up, right? And there's some other stuff it talks about where it changed the medical loss ratio. Basically, there used to be a lot of padding in there, and I'm not saying there still isn't, but there was definitely a lot of padding in there when money went to administration and stuff like that. Like there's a story about AIG was sending folks all over the world and just, throwing money in the stock market, all kind of things. What they've made now, where they supposedly audit you and make sure that 80 to 85% of your premium is actually going to your coverage. Now, did you know that a part of your premiums go into the stock market? I can tell you somebody that used to sell insurance, yeah. They take your money and they put part of it in the stock market. There's something, if you ever get them pinned down, it's called, when I used to sit there with them, it's called, you talk to the underwriters, it's called cost of insurance. Sometimes you can find it if you dig through all that crap. The cost of your insurance, okay, here's an example. I have a VUL, that's a variable universal life policy. That's the ones where you, well actually that's a bad example. Let's use whole life. Because that one actually is designed to go in the stock market. But there's a cost of insurance. That's what you cost. And then there's a markup for them, to make profit. And then there's a little extra, and they take that and invest it. TXU does on my electric bill. I don't know what that was you talking about. I don't know. Well, if State Farm and somebody's doing a commercial now, if you're a good driver, we'll give you some money back. I don't know. I'm really trying not to talk about insurance companies, okay? So I'm trying not to get into, anyway. I've been behind the curtain is my point. That's why I gotta say this, that's why that big real estate crash affected everybody. The money you were giving them was in the stock market and it crashed. They were throwing them in what they call tranche funds, real estate investments, and they had debt swaps. I could go on and on. It was all hedged and backed up, and they thought they were good because if it went up, they won. If it went down, it was insured against it. And AIG, who was insuring them, which is one of the biggest ones, they were doing it too. They were like, oh, cool, we'll take some of our money and throw it in there. And they lost their money, and nobody had money. Anyway, all right, I'm trying to keep it moving. Covers preventative care costs at no cost. The consumer may be eligible for recommended preventative. I'm going to skip this stuff. It gives you a right to an appeal. The big thing you take away from this is it ended pre-existing conditions, exclusions. Health insurance companies can't refuse to cover you or charge you more because you have a pre-existing condition. That is a health problem that you had before the date a new health coverage begins. That is somewhat true and somewhat not. They still can take into account what you're going to cost because they got to stay in business. So to say that you're not going to have high insurance because you have a health, you'll get insurance if you can afford it. It just may not be as crazy as it used to be, okay? So Medicaid, it got established in 1965 as a part of the Social Security Act. It was basically originally designed, and let me talk about Medicaid now because Medicaid is the one that you guys will probably deal with the most with your clients. If you have clients that are disabled, particularly if they're on Social Security, SSI, they will automatically qualify for Medicaid, right? So it came in 1965. It was originally thought of as a way to help low-income persons to pay for health care. That should say low-income persons with disabilities. Who gets it? Again, SSI, that's just recipients. Persons in nursing homes, that's called long-term care Medicaid. If you go to a nursing home, unless you're rich, and maybe somebody here is, but unless you're really, really rich, let me clarify that, you're going to be on Medicaid. So when people tell you, oh, Medicaid sucks, till you need it. Yes, 5 years. So if you decide that, hey, mom, I got a great idea. You know you're about to go in a nursing home, give me the house. And then you can go to nursing home. No, guess not. Mom's penalized. She doesn't get Medicaid. Can't do a transfer like that. The mom is allowed to keep the house. She can keep the house as long as she tells them, I'm going to go back one day. She could be 90 years old. I'm going to go back one day. If she says that, she can keep the house. But they can put a lien on it and take it, which is why people try to transfer it out. So if you see this coming, if you want to talk to your mom, I'm not trying to, because some of this stuff gets to y'all exploiting people, okay? But I'm going to tell you, go to an elder law attorney. They're called elder law attorneys, probate, certified in probate, and let them do planning. You should probably do that anyway. I'm like the barber that never gets a haircut. I should be doing all this stuff and I don't, and I know it all. But, So anyway, I had this barber. His hair was looked like Don King. Never cut it, but he's a good barber though. So it deals with children in foster care. They automatically get it. Pregnant women. Depending on income. All this is dependent on income too. Individuals who are blind, visually impaired, depending on income. And this is just an illustrative. It's not an exclusive list. I talked about the expansion a little bit. In states that did expand, not Texas, this is the thing you need to take away from the expansion. It used to be that you had to have a disability, barring that you're in one of these special groups. You had to have a disability and you had to be low income. With the expansion, all you needed was the low income. Okay? Really low income. And that was supposed to catch the group in the Affordable Care Act that you hear about that says, I can't get insurance. Because they were supposed to be in the expansion. That little group that makes just enough that they can't really, they're just enough to not qualify for SSI, but not enough to buy it. That was that group. But now that group still has to be disabled. So that's why the expansion. So when y'all get these clients, you can't feel, why they don't get covered? Well, if they're on SSDI, they're probably in that group. Now they'll get Medicare in 2 years after the wait, but they're in this limbo, right? Now I'm gonna tell you this: a lot of stuff I'm telling you is not gonna give you the answers to your problems. I'm just telling you what the problem is. Okay, all right. These are the barriers, right? So basically, if your state has an expanded Medicaid, which you live in Texas, your income is below the federal poverty level, and you don't qualify for Medicaid under the state's current rules, you won't qualify for either health insurance savings programs, which means you can't get into the deal where they give you the subsidy in the Affordable Care Act, and your Medicaid coverage or savings on a private health plan through the marketplace. But with all that being said, I still tell clients to apply because a lot of times they could get a better deal anyway in that exchange. A lot of times it's just cheaper than the open market. Sometimes it is, sometimes it isn't. But they should go look in the exchanges. You should always tell a client to go look in the exchanges and see what the deal is. Don't just give up and assume you don't have health care. Now this is what I wanted to talk to you guys about. Karen and I had a big conversation about this. In most cases, Medicaid is the payer of last resort. This causes a ton of confusion. It confused me. Karen and I had to sit down and get this straight in our head the other day. Literally, 3 days ago, right? Because Medicaid is like, we pay last. We do not pay if anybody else can pay. But VR is. VR will not pay if they have Medicaid. But a lot of people with Medicaid are like, no, we don't pay. You can get it from somewhere else. So sometimes the hardest thing with Medicaid and Medicare for your clients is getting a denial. You got to get your clients to get a denial. Because without the denial, you can't even bring it back to your people, okay? And the other thing about it is this, and there's a pecking order. I told you you're going to be more, I'm looking at you, you're going to be more confused listening to all this. There's a pecking order. Who pays first? Wrong, Medicare. Everybody, you beat me to it. I was about to say, who pays first? Medicare pays first. Medicare is the best insurance on earth. Quiet as kept. Doctors love it. They'll tell you they don't. They love it. I work with doctors. My wife's a nurse. My clerk right now used to do billing for doctors. They love it. But they'll tell you they hate it because they're scared it'll expand to everything, become one single payer system. And if it did, then what is the biggest problem facing us with healthcare today in America? Anybody? Prices. you could bring the cost down because the government will say this is what I'm going to pay. So they tell you they hate it, but they love it. Because all the rates are based on Medicare. It's a system called Interqual, I think it's called. And you put in a computer, and it's a system they all plug it into. They're all based on that. Medicare sets the mark, the pace setter, right, for what the price is. So being fragmented the way it is now benefits people because doctors, again, I said they have a better press agent. Hospitals, they can jump in and out of systems depending on what pays them more, right? And if their caseload, they call it a census, gets too out of whack and they're getting too much Medicaid, they're getting too much of this insurance company because this insurance company tries to bring the price down. I saw this with Aetna. People start dropping Aetna. Aetna not paying enough. We want United. It's a game. It's money. Okay? So Medicaid thinks it's the last, and you see I have VR as the last resort. So Medicare pays first, right? Then Medicaid, Medicare, then private insurance, then Medicaid, and then VR if you don't have nothing else. And somebody's trying to go back to work. So I was going to tell y'all about waivers. What, I got 10 minutes? No, I can do it in 10 minutes. What y'all got in 10 minutes? All right. I don't know if y'all already know about waivers. I'll just tell you what waivers are. It could be somewhat helpful. Waivers are designed under the Americans with Disabilities Act. If a person otherwise could receive a service in a community, medical service or support, they can get it in a community as opposed to being an institution. There's a Supreme Court case called Olmstead versus Georgia, where someone sued and said, you're forcing me to be, I think in a nursing home, I think it was, to get services. You're forcing me, as I have a disability, to be institutionalized. They said, the Supreme Court said that is illegal. That's discrimination. So waivers come out, right? And the waivers say, now it's still about money. All things being equal, cost-wise, and a lot of times in the community it's cheaper. In fact, I'd say 80% of the time it's cheaper. The states didn't really understand this at first, then they started seeing it. They said, okay, let's move these people in the community as opposed to having nurses around the clock and all that. Maybe a nurse checks on them, 4 or 5 times a week, for maybe an hour. They have an attendant that comes in for 4 or 5 hours, something like that. And they're not getting that around the clock care. So it's cheaper. So that's what waivers are. And they would say waive off of things. Nursing facilities. Let's jump ahead. We waive off for nursing facilities. The one that says MDCP, that's for children. That's in a nursing home. The one we call Star Plus at the bottom, that's for adults in a nursing home. So they could come out, take the services with them, bring the mountain of Muhammad, so to speak. Class, that was for someone who'd otherwise be in an ICF, IDD, or used to be called an ICFMR, if you've ever heard of those. That's how they come out. Home and community-based services, anyone heard of state schools, state supported living centers? That's how they come out. Deaf, blind, forget what the multiple disabilities. You got to be deaf and blind to get on it. And that one is to keep you out of like nursing homes and things like that. And then yes, that's a newer one that they're still working through, but that's a mental health waiver. It's still not very robust, but it's okay. And Texas Home Living is like what I call a state supported living center, state school. It's it's almost like Coke Zero, but for the ACS, because the ACS goes to like 168, and that's like $14,000. So I would say light, but it's really like Coke Zero. So, but what kind of services can you get? You can get the portable in that regard that it goes with the person. The eligibility is based on the person and not the family. That's big because a lot of people, they count family income, household income when they're trying to make, this is based on the person with the disabilities income. So odds are a lot of times they're eligible. because most cases they either have SSI, SSDI, or nothing. The waiver is a mechanism for individuals at 300% of SSI to become eligible. So if you have somebody and to be eligible, normally for Medicaid is 100%. They basically it's like what is SSI right now? It's 750. If they qualify for a waiver, you can triple it, how much they make, and they can get on. You can't make any more than $2,000 a month, and they can't have any more than $2,000 in a bank. That kind of sucks. But they can make more and spend it as long as they spend it on stuff and keep it under the income, but they have to go through this calculation every month. So it's also called a waiver because it waives a lot of requirements. One of the requirements of Medicaid is called comparability, which means that it's got to be the same for everybody. They can actually pick and choose who they put on it. Like you heard, they targeted different groups, persons with IDD, persons with related conditions, persons with visual impairments, hearing. They can target a group to try to get that group out of an institution. So they cannot duplicate what's in the Medicaid state plan, and it's not an entitlement. Medicaid is an entitlement, so is Medicare. It is, though it's, I'm sorry, traditional, regular Medicaid, SSI Medicaid. People always call stuff entitlements that's not. An entitlement means that you meet the criteria, you get it, period. Now with waivers, there's a wait list. Right now the one HCS, that's the best one, 15 years. 15 years. Now you can jump the line. You call me. There's a way to jump the line, but everybody can't just jump it. But there's loopholes that I could get into. Okay, but anyway, but they're great. Another thing about once you get on a waiver, it puts you on Medicaid. Period. So you get all of the stuff Medicaid gets. And all the services you'd have gotten in an institution. That's what I say every day. Which is a part of my class action lawsuit. What's the point? They need to. They need to. You need to sign them up immediately. And like for the one, like if you have a kid with a developmental disability, you need to go down to your local. They used to be called MHMRAs. Now they're called something else, depending on where you are. Yeah. But you need to go tell your client, go down there now and get your kids signed up. And they don't go. They've been on the list. They're not going. They have to leave. Another thing, the services like the one HCS, that one gives you group homes. That's why everybody likes that one. But the services, you can still get HCS in your house. And when you pass away, do you want your kid to be in a state supported living center with people they don't know, or do you want them to be in a small group home with maybe 2 or 3 people? Now let's think if this kid got medical issues. Do you want them to have 45-to-1, 50-to-1 ratio provider? Or do you want them to have 3-to-1? To me, this is math.
But the agencies have also another set of criteria that, and they confuse the customer by saying, well, which waiver do you want? And so I taught my students and parents and
Right.
students to say, you want all of them.
You want to be on all of the lists. There's two ways you get on it. For nursing facility stuff, you call, like if it's a nursing facility, a pure medical thing, you call 211. All right? If it's a person with a developmental disability, you send them to the local authority. There's actually other ones, but again, it starts getting confusing. But those are the 2 big ones. That covers like 95% of it, okay? But you're right. Well, I will say this one. I didn't want to do this, but I will say this one. MDCP, the one for children, because I got to say this. And this is actually a good segue. You'll see that they have to coordinate with the state plan. The state plan is just regular Medicaid. If you're on Medicaid, you get these services. You get physician services, hospitalization, durable medical equipment, DME. That's a big one, right? Well, it depends. I take it back. Kids get this. Okay, let me say that. Um, adults can get it, but it's a bigger hassle. Um, and they'll give you wheelchairs and stuff, but there's like prosthetics, orthotics, and stuff like that. They don't like giving those out. I don't know why. I had a client with needed a $4,000 surgery, no, $14,000 surgery, or a $400 orthotic, ankle foot orthotic. I went to him and I said, the doctor says you give them the ankle foot orthotic, they won't have the falling, or whatever we call it, plantar. It was some issue they were gonna have, and they were like, well, it's not on the list. So you're gonna pay $14,000 for a surgery when it comes up. Well, we're not gonna pay $14,000. We don't pay that, but we'll pay whatever the surgery costs. If the doctor takes it, right? That's the other issue, right? You have folks, and let me talk about this too. I can't do this without talking about this. Is MCO, what does that stand for? It should stand for managed costs. All the states are moving their stuff into these managed care organizations, and now all of a sudden, remember I said people don't normally get into things if there's no money, and one of the main ones is insurance companies. They don't deal with stuff that doesn't have any money. But all of a sudden, they went to managed care organizations, and now we had like 3 MCOs. We had Superior, we had Molina, and AmeriGroup, and there was one called Evercare, 4. Evercare got bought by United. Then, just this year, when the whole thing went managed care, we now have Aetna, Children's Hospital, 2 or 3 children's hospitals, Cigna. I can't keep up with them. They all, every insurance company you can think of suddenly is loving Medicaid. I'm like, why is that? Because it's called capitated rates. That's how managed care works. They do an assessment before the beginning of the year. They say what you're going to cost based on your experience rate, right? This is what we think you're going to cost. And Bob's my boy. I like you, Bob. You're my man. They say Bob is going to cost us, we did the numbers, and Bob should cost us about $15,000. Put a little taste in there for you guys, a little profit, administration, wink nod. Okay, $25,000 for Bob. And then Bob he gets sick, and Bob cost $150,000, or God forbid, $1 million. They eat it. They eat it. But what if Bob only costs $5,000? They keep it. I gotta wrap up. That's a different thing. The deductibles and the stop loss, and oh my goodness, if I start getting into deductibles, I'll make your head hurt if you want to.
Actuarial rates
Yeah.
they use to make sure they'll make money, even though I might cost them 150. There's some 500 others.
But yeah, but theoretically someone's going to go over, right? So their deal is to keep your costs down. You know, it's like if you got a Did you take it nowadays, right? Hey, did you go to, we noticed you didn't get that prescription filled. They keep it. And they throw it in the stock market. Here's a program you ought to know about, Medicaid buy-in. Y'all know about this? All right, well, Medicaid buy-in is still not that high a threshold, but if someone's a little bit too high and they don't fit all the other stuff, they can't get on a waiver or anything, but you're still trying to get them health insurance and they're working, they can buy in. They pay a deductible. Okay, that's your deductible. Ticket to work, I'm not going to get into this. You guys can teach me about ticket to work. You can, right? Okay. Not to be confused with Medicare. Medicare is different. Medicare is, I get people mix these up all the time. Medicare, you're age 65, and you're paid into the system, enough quarters. You get Medicare after 2 years. Okay? Or you have end-stage renal disease. Somebody in Congress somebody must have got end-stage renal disease and they made an exception for that. I was wondering, like, why is that the only one? So anyway, yeah, well, yeah, the dialysis clinics, I guess. More powerful lobby than I thought. So anyway, younger people can get on if they're disabled, if they paid in enough quarters prior to becoming disabled. And they go through 5 million appeals with the Social Security Administration, because unless you're a W amputee, you're probably going to have to go through at least 3 appeals. Key differences, there's Part A for hospitals, Part B for outpatient. Now that used to be C, now it's D for prescription. There's a donut hole in that too. I forget how it works, but there's a donut hole with the prescriptions. It's like there's a part it doesn't pay for. I don't remember off my head. The difference though with Medicare, it's insurance. It's a weird insurance though, right? Because you pay for it your whole working career, and then you get on it and you keep paying for it. Right? So they take it out of your check, your Social Security check. It has payments and deductibles. Do you know there's a deductible on blood? Like they give you X amount of pints, and then after that they cut you off. I forget how many. I think it's like 20 pints or something, and they cut you off, and then you have to like pay for the next set, and then it comes back on again. Yeah, that's Medicare. That's why it has Medigap. If you can afford it, you better get Medigap. Medigap. Because, of course, the insurance industry had to get their beak wet. So we won't really take on any, and remember, Medicare pays before private insurance, right? So once you go 65, Medicare kicks in, your insurance is just Medigap, if anything, if you still have it. You might as well drop it and get a Medigap policy, right? Now the Medigap, now here's the thing about Medicare too though. Medicare is going MCO crazy, right? They have all of these, in fact United Healthcare is one of the big ones in this. I think Cigna is. They're becoming, so like again, you hit a certain thing and you want to know why they're giving you grief about something, because they keep the money, okay? But you need to have Medigap. Like here's another one, like if you have to go into a skilled nursing facility, not to be confused with a regular nursing home for a chronic condition. I'm talking about you have an acute thing, or a LTAC, long-term acute care. So let's say you have intravenous antibiotics. You got 100 days to get over it. Huh? That's right. That's right, on the first 20. So then it starts going up. So you got 100 days. Or you better become a chronic thing where they can shoot you over to Medicaid and throw you on the other side, the crappy side of the house, you know, the one they wheeled you past until you don't look at them. That's not you. Now, you know how you go through first class, you know, kind of thing? Except it's the reverse. Now they wheeling you out of first class to the coach. Does not have the same level of prescription coverage. And so Medicare, single-payer national social insurance program, came on in 1966. It's funded by payroll tax. We talked about that. Got to be 65 or disabled. Provides health insurance to younger people if they have, we talked about those disabilities. If you're on SSDI, you get Medicare after 2 years. And there's another thing that happens. Somebody will be on SSI and they're doing fine because they got Medicaid. Then they Social Security appeal and all that goes through. The quarters come through. They get the SSDI. Now they make too much for Medicaid. But they're on a 2-year wait for Medicare, right? So again, if you can afford it, Medigap is great. Medigap takes up all of these little loopholes when you're on Medicare. So that's something you should take away from it personally. Investigate a good Medigap coverage because you will need it. So when can we help? We consider the merits of a person's case, so Wallace brings it back to us. When you can call us. We can't take every case. We got to look at the merit of it, whether we have resources or funding to take it. There's certain things we're funded to do, certain things we aren't, but we're pretty broad. But we basically, with the health insurance stuff, for instance, we basically focus on Medicaid because that's the greatest need. We can give some advice on Medicare, but we can refer you to this program called the Texas Health Law Program. Volunteer Legal Services is a great program. They have lawyers on call, and they will talk clients through stuff. We can also refer you to healthcare navigators and things like that. We can refer you to prescription drug plans. A lot of the insurance companies in a crisis of conscience realize, now I'm talking about pharmaceuticals, I should say. Oh, I'm not even talking about pharmaceuticals. But they came up with these programs where they put certain things on a discount, right? So we have a lot of information if you need it. But again, it comes down to whether or not we have people to help you at that time. And we also look at, and particularly my team, look at systemic stuff. We try to take cases that it helps a bunch of people. Like it may be one person, but if we can fix that thing, it helps a bunch of people. So we'll take that before we'll take a one-off. And how do you get us? You can call our intake line, 1-800-252-9108, and one of our helpful intake specialists will obtain information about the problem. The case is then forwarded to the appropriate team, and we staff it. And that's it. That's our number again. That's our website. Thank you. I want to do this in 6 minutes. Doesn't matter.
Thank you very much, Sean.
Thank you.
Thank you. Thank you, Drew. Microphone.
Oh, yes, sir. Oh, yeah, definitely take this to Mike.
Very good. Folks, we have the certificates for the last two programs this afternoon. Let me see. Okay, good. Yeah, okay. Very good. So, folks, we will reconvene tomorrow morning. And let's see. We are scheduled for, we'll open at 9 a.m. tomorrow morning with an outstanding speaker. He is phenomenal. That's me.